Hi, I'm Josh McDonald.
And I'm Miranda Materi, and we are Hand Therapy Academy.
Today we're going to talk about VISI and DISI. And if you don't know what those are, we're going to talk all about it, explain what it is, VISI and DISI.
All right, Josh, and what does the VISI and the DISI stand for?
Volar intercalated segmental instability and dorsal intercalated segmental instability. Rolls right off the tongue.
Yeah, it does, doesn't it? And this is a
Right.
topic that I feel like you have to know for the exam. There's usually one or two questions always on it, and very good to know in clinical practice too, because it does influence the exercises that you're going to do with the patient.
Yeah, it's something that's one of those, I wouldn't say it's a niche topic. It's not going to be your bread and butter of what you see coming in every day, but it's not exactly the zebra that hardly ever comes in either. You're going to notice like scaphoid fractures, scaphoid lunate ligaments, and just strains and sprains and stuff. And you're going to say, hey, maybe I need to treat with this protocol or this direction of stuff because of some of these ligamentous instabilities in the proximal carpal row.
Right. And this is, I feel like, a topic that more and more research comes out all the time, and it's changing quite rapidly. So good to stay abreast and good to know what it is.
Yeah. And we get a bunch of members asking questions about it too. It's one of those things that is a little obscure and quirky and a little hard to wrap your head around. So why not tackle it on a podcast this morning?
All right. So this is our first podcast. So our first official topic one. So we're going to really try to nail it. So we might talk about it and talk about it in a few different ways to really kind of cement it in. But first, I want to talk about a scapholunate injury and what type of instability this typically leads to. So scapholunate injuries usually occur from a twisting motion of some sort. So I always remember this one because I had a patient that came into the clinic and he was getting handcuffed, and his hand got twisted into the cuff. So he sustained a scapholunate injury from that twisting motion. So the mechanism of injury is typically a twisting motion that occurs, and this can lead to an SL injury. And we know with SL injuries, this can lead to a DC, so the dorsal intercalated segment instability, versus say an LT injury. We know that this typically occurs when you're falling backwards, like on an outstretched hand. And this is when you have an LT injury, and these LT injuries typically lead to a VC. And since Josh is very analytical, he is going to be talking about the mechanics of a VC and DC, and he's going to really drive it home.
So I'm not sure if that's a compliment or not, but it is accurate.
It definitely is.
It's accurate. So we'll run with it. Okay, so if the lunate is our anchor point in the center of that proximal row, you got the scaphoid on one side and the triquetrum on the other. There's supposed to be a ligamentous connection connecting the lunate to the scaphoid and the lunate to the triquetrum. If I have that rotational injury that Miranda talked about and it disconnects the scaphoid from the lunate, then the lunate can't stay anchored in the center. It's lost half of its anchor. So now when the wrist moves, the lunate travels exclusively with the triquetrum where it still has its connection. If you have an LT ligament injury, you lose that connection, so the lunate travels only with the scaphoid where it still has its connection. So why do we call it volar or dorsal? If you lose the scapholunate connection and it travels only with the triquetrum, then the lunate migrates dorsally because the triquetrum during certain movements of wrist flexion and extension will travel mostly dorsally, and it collapses dorsally when it's not tethered to that scaphoid over there. So when you lose the SL ligament, the lunate collapses dorsally. The opposite happens when you lose the LT ligament. Then the lunate's traveling with the scaphoid, which tends to move volarly, and so you have a volar collapse of the lunate. So you have a VISI, a volar intercalated segmental instability. All the other words are important, but we're looking at volar and dorsal. So SL ligament rupture makes the lunate go dorsally with the triquetrum. LT ligament rupture makes the lunate go volarly with the scaphoid. Hopefully that makes some sense. It's hard without doing all the visual stuff because I'm a visual learner and I'm a hand talker. So hopefully it comes across okay in audio only.
Right. So would you say the lunate, it's VC and DC is always determined by the position of the lunate, correct?
Yeah,
So
yeah.
if the lunate is volar, then it's a VC. If it's dorsal, then it's a DC.
Yeah.
And
Yeah.
which one would you say is, I'm sorry, go ahead, and I'm gonna ask you your next question.
That's
I cut
okay.
you off.
I would say that knowing the direction that the lunate's going to go is whether it's volar or dorsal, but then you got to know which direction that lunate's more likely to go with each injury. So scaphoid, it's going to fall back because it's connected to the triquetrum. LT injury, it's going to fall volarly because it's now married more exclusively to the scaphoid.
And which one is more common, or which one do you more commonly see?
SL ligament that leads to a dorsal intercalated segmental instability. That rotational load, I feel like that is a more tenuous bond, and then it's also a more common mechanism of injury. So I see a lot more SL. How about you? Do you see kind of the same frequency
I
there?
think definitely way more SL. So you see way more of that twisting motion and that type of injury in the clinic, and far more, I think one of the most common instability patterns is a DC. So that's definitely contributed from the SL injury.
Yeah. I remember going to a conference at ASHT a couple of years ago, and we sat through this fantastic lecture all about wrist instability issues, and they covered all kinds of treatment for it, and they focused almost exclusively on SL. And I was a very new budding therapist, and I went up and asked later, and I'm always asking questions and being that student at the end that's got more questions. And I said, okay, so what's the treatment stuff for LT? And they said, honestly, kind of the same stuff. So it's good to know what you've got, but sometimes it's, the treatment may be very similar for different aspects, but it's good to know what you've got. So Miranda, what would you say is a good treatment strategy, treatment plan for an SL ligament dorsal intercalated segmental instability?
Yes. So with the SL injuries, I typically start within a dart thrower's plane because we know that those are pretty safe to do, right? So I had a patient that was sent to me for a wrist sprain from a primary care doctor, and he had failed the typical therapy because he went to a different clinic where it was just more of a they didn't have hand therapists there. It was more of a full body place. And not that that's bad either, because I know a lot of full body places can do wrist treatment too. But long story short, he was doing a lot of wrist extension and strengthening his ECU, and he was still having a lot of pain. So when he came to me with the SL injury, it was me like educating him on how, that therapy might have, wasn't as successful, because when you strengthen the ECU, you're actually putting strain on that SL ligament injury, right? So it was reverting back to what are safe SL movers. And we know, it's the FCR, the EPL, APL, ECRB. So moving in that safe dart thrower's plane. So, and actually FCR, they say that's somewhat controversial. It depends on if it's a complete or incomplete, but definitely FCU, ECRL, ECRB are the safe ones that you start to strengthen, and then doing a lot of proprioceptive stuff.
Yeah.
How'd I do? You kind of caught me off guard with that question.
Sorry, you did fantastic. Let's
Yeah.
maybe back up. And for those who may not be comfortable with dart throwers and what that is, you can visualize what it looks like throwing a dart at the dartboard. That movement, it is a combination of wrist flexion and ulnar deviation. That's the anterior-ish movement, and then it's wrist extension and radial deviation. So if you're driving in your car or something, do that movement like you're throwing a dart, light and easy movement. And what that does is the scaphoid, when I flex my wrist, the scaphoid goes into flexion. When I extend, it goes into extension. When I go into radial deviation, the scaphoid also flexes, and when I go into ulnar, it extends. So what dart throwers does is it pairs together wrist flexion and ulnar deviation, which one flexes and one extends the scaphoid. So net loss, scaphoid doesn't go anywhere. And then it also pairs together wrist extension and radial deviation. Again, a scaphoid extender and a scaphoid flexor. And by pairing those together, again, net zero, the scaphoid doesn't go anywhere. So I can get functional range of motion. I can get articular surface glide on the distal end of the radius. I can get all kinds of good blood flow and synovial fluid changeover. But the relationship of the scaphoid and the lunate doesn't actually change because I'm pairing together two antagonist two movements that cancel each other out. So I can do wrist motion without that SL gap forming. And what Miranda was talking about was this patient was going to a clinic where they were doing wrist extension flexion and just kind of banging that drum a bunch. But that strengthens the ECU. And the ECU pulls us into extension and ulnar deviation. Those are both scaphoid extenders. Well, if I have two scaphoid extenders, that's pulling the scaphoid away from the lunate. I want to strengthen or activate and neurologically improve the proprioception of muscles that are complementary and not two that do the same motion of extension or both the flexion of the scaphoid. So we're trying to cancel out so we have less movement between the scaphoid and lunate while still getting some dart throwers healthy movement of the wrist in a very light, gentle range.
Yeah, that was excellent.
All right. Okay, so if we're doing dart throwers, day one they come in, and I've gotten this question several times. Day one they come in and we show them dart throwers. Great, that takes 5 minutes, maybe 10 if they aren't getting it. Use the other hand. Okay, then what?
Yeah, and I mean, and sometimes too, Josh, I feel like showing patients dart throwers is hard for them. I don't know what it is. So I'll do like picking up a paper cup like you're gonna drink it. And I feel like that's kind of a similar motion. So okay, so if they got dart throwers, then what? What are we gonna do with them?
Yeah, so that's tough because this is a patient that doing wrist movement that they do all day long makes things worse. So I'm not necessarily going to do a bunch of wrist movement. I might do stabilizing stuff, proprioceptive stabilizing stuff when I want everything to kind of co-contract. So I might maybe I pull out my yellow power web, my lightest one, and I hold it kind of on a vertical angle, not totally vertical, maybe leaning on the table in their lap. And I say, I want you to take a fist and act like you're going to lightly punch and gently press on that and just hold it there. And as long as the axial load doesn't cause compression pain, they're stabilizing like someone standing on one foot. Their ankle's super active, but they're not really going anywhere. But all those muscles are co-contracting, causing good circulation and proprioceptive awareness and not significant load. I grab my light power web, but I'm doing some light stabilization stuff. I'm not doing weight bearing on their hands in a push-up plank or something, but some light proprioceptive awareness stuff just to kind of say, hey, let's just turn this body part on and see what it feels like to have load and compression with no pain and light proprioceptive input.
Right, so they're getting that input. Yeah, sometimes do you ever do isometric strengthening?
Yes, yeah. So isometrics is great, but again, we're focusing on what they call those SL friendly muscles and not the SL unfriendly muscles. So an ECU is going to be an unfriendly muscle because it pulls that wrist into extension and ulnar deviation. So we don't want to strengthen ECU. I'm going to do isometrics of APL and EPB because those are going to pull me back into that wrist extension and radial deviation. And a little bit of FCU, pulling me into that forward flexion and ulnar deviation. Think about the muscles I would need to go into dart throwers. Those are the muscles I'm going to use for isometrics. No travel, just isometrics. Yeah. And then if you get that quirky every once in a while, it's an LT problem, theoretically, you would reverse all of that. But man, if you think teaching dart throwers is hard, try to teach reverse dart throwers. You have hardly any range of motion travel at all. But if dart throwers does what it says it does for the scaphoid, it's going to do the same thing for the triquetrum. So my treatment activities are going to be darn similar to that, except my friendly and unfriendlies are reversed. So I'm going to work on ECU isometric stabilization and not so much on FCU and the APL and EPB and ECRL. So different muscle groups for isometrics, but the dart throwers still kind of locks that whole row in place because those are antagonist movements that keep the scaphoid and the triquetrum from moving differential from the lunate.
Right. And I don't know if you find this in your clinical practice, but a lot of times when you have those patients with LT injuries or injuries more like towards the lunate, that they have a positive ulnar variance. Right. So sometimes I'll play around with, are they doing activities in supination or are they doing them in pronation, to alleviate some of the pressure, because as we know with supination, you can unload some of the forces on that ulnar side of the wrist versus doing them always in pronation.
Yeah. Yeah. And that's just a matter of that rotation of the radius and its relationship to the length. The further that radius has to go around the ulna into pronation, the more the ulna, relatively speaking, sticks out a little bit further and causes more impaction. If they are having that ulnar abutment or that ulnar variance that sticks up a little bit and they have pressure with that, then I definitely would not do any compression. If any patient has pain at the ulnar side of the wrist with compression loading, that's a no-go for sure.
Right. Yeah, definitely.
Yeah.
All right.
That is a ton of information that we just packed into, I don't know, 10 or 15 minutes or so.
Yep.
Yeah, super exciting stuff. Definitely it takes some time to review that stuff a couple of times. Get yourself some 3D models. We've got videos on it that are on YouTube and some of our other channels and such, so you can watch some of those, but lots and lots of stuff to try to wrap your head around there. But definitely spend some time on it, get comfortable with those concepts.
All right, guys. See you later.